From where we just left off, we're going to start talking about type 2 diabetes. Now, type 2 diabetes has a slightly different, it has a very different profile and a different pathology, because here what we're talking about is there's not been damage necessarily to the pancreas. What is happening here is either the pancreas, for whatever condition, whatever reason, has begun to slow production, is still functional. That's the key here, is with type 2 diabetes, these patients are still making insulin. This is, if you're going to have diabetes, this, I guess, would be a type to have, because you still have some preserved pancreatic function. Now, the difference here is either the organs are resistant to the insulin that is produced, they are moderate in their response, they perhaps respond but not as completely, or there is impaired insulin production, secretion, for one reason or another. Either the insulin is not sufficient or the organs are not responding appropriately, and it may be insufficient in the type of insulin it's produced. It may have been altered in genetically or in its production, and it's only moderately effective, or the organs themselves may not be responding. So this is 95% of the diabetic population that you're going to encounter out there. A majority of them have onset over the years. Majority of this demographic is onset over the age of 30. So this is significantly different than the type 1 profile, which can have onset from various periods of time, but it's not uncommon that it happened in a younger population before the age of 30. This particular type of diabetes is increasing in children, as I mentioned earlier, and that's most likely related to obesity. There seems to be a correlation between the incidence of diabetes and the increased incidence of type 2 diabetes. So that's a concerning hallmark going forward. This is a slow progressive glucose intolerance, and it may go undetected for many, many years. These are the kind of things, as you've seen already, the subtlety of the symptoms for diabetes. These could easily be rolled into associated symptoms with other conditions. And if the glucoses on any given day are okay, and a provider is not dialed in to double check, hey, we see this and we see that. Yeah, you think it's because of your COPD, but maybe we should just go ahead, and since your glucose is 125 fasting, let's just check an A1C just to be sure. This kind of diabetes may not be picked up on. So that's one of the dangers of this. So it could go on for many years and not be treated. And then you can have people like my brother who just say, well, I'll just get the type 2 diabetes and then take the medicine. So that you can see where that could be problematic. All right, so we still have some complementary issues here. This slide just kind of encapsulates some of the physiology here that we have in the case of type 2 diabetes. Impaired insulin secretion, which produces hyperglycemia. Again, like type 1 diabetes, that's going to be one of the hallmark symptoms, is high sugars. Also, you're going to have a decrease in gastrointestinal absorption of glucose, partially because of that change in gastric motility like we were talking about earlier, and increase basal hepatic glucose production. So what that means is, back to what we were talking about with gluconeogenesis, if the cells are not getting sufficient glucose, then the liver is going to try to make a contribution by breaking down fatty acids and producing. So you're going to have some of that, as well as muscle tissues, again, reflecting the lack of sensitivity to the insulin that's out there. Muscles and other tissues are going to do less glucose uptake because of insufficient insulin production, too much fatty tissue around the tissues, or alteration in that insulin that makes it less efficient in doing its job. So similar complementary type issues with type 2 diabetes, but the core pathology is yet a little different. Now, the presentation is different because I'm just comparing the two here. Type 1, we talked about it typically, characteristically having an early onset, having a familial connection, a genetic predisposition. That was what I mentioned on the slide. And then it's triggered by an immunologic trigger that causes the breakdown or deterioration of beta cells. Now, type 2 is different. It is commonly associated with obesity. It's characteristically later in life, as you saw just a moment ago, at the age 30 or later. And it has been previously identified impaired fasting glucose or impaired glucose tolerance test. Perhaps they've had a pre-diabetes test at some point in the past, and now they're developing the type 2 diabetes full on. Like I alluded to in one of the very early slides where I showed you the progression and evolution. So that could have been missed, or it could have also shown up. And you see here hypertension as a characteristic of type 2 diabetes that's not listed as associated with type 1. Hypertension is not necessarily an issue there, but it is with type 2. And possibly a history of gestational diabetes or a baby that was born over 9 pounds. Those can be predisposing factors to type 2 diabetes. And then you also see here low HDL cholesterols and high triglycerides. So very different profile as far as the demographic for presenting with type 2. Now, as far as medical management goes, the goal is going to be to normalize insulin activity. That's important distinction from type 1, because type 1, there's not going to be any normalization of insulin activity. There's going to be supplementing insulin and normalizing glucose levels. But in this case, we want to optimize the insulin that's currently working. And there are several avenues for that. That's why there are different insulin or glucose lowering agents that we will discuss. Got a table for that we'll get to later. But then also we do want to manage glucose. So glucose is, again, it's the symptom, but it's an important keystone, capstone for the management of diabetes in all forms, because that glucose, that simple test, is showing us how we're doing in this case, normalizing insulin activity, but in type 1 diabetes, replacing or supplementing insulin. Now, here is a difference. I alluded to this earlier. You see here, hemoglobin A1C less than 7. This is for the management of diabetes, not the diagnosis of. Those are two different things. So diagnosis, greater than 6.5. Management, less than 7. Two different questions, two different stages of the continuum for diabetes here. Basically, diabetes has 5 key elements or components as far as the management goes. Nutrition, we've got to get the right food in the right balance. These patients need to have some form of exercise in all forms of in all forms of diabetes. Exercise is a key component in helping maintain or manage the condition, not just from a physiologic standpoint, but from a mental and psychological standpoint as well, because exercise just helps you feel better as well as kind of maintaining that normal physiologic balance of those hormones from exertion. Monitoring, in this case, we're specifically referring to glucose monitoring in all of its forms. And that could be fingerstick glucose, it could be lab work at the physician, and it also involves monitoring hemoglobin A1C. There's going to be a pharmacologic component here, unless a patient happens to be able to change their diet and lifestyle to such a degree that they lose enough weight and normal with type 2 diabetes and normalize their sugars with just these first few components, then it's possible they may avoid pharmacologic therapy. Sometimes it's inevitable. Characteristically, this is going to require an oral hypoglycemic agent or an oral glucose lowering agent that we're going to talk about in a bit. It can include insulin, but may not. It can commonly include multiple agents. We can use these in various combinations. The last thing here is education, and this is going to be one of your biggest roles, not so much in doing the education, that may be a component of it, but getting the patient connected with the education they need. A lot of hospitals, because of the complexity and readmission rates with diabetes, will have diabetic educators to help get people tuned up or get them on board and then keep them tuned up with their education. You're going to encounter patients who are completely dialed in, and they may know more about diabetes than you do because they're reading about it constantly. That may be the case, but most patients are going to need your guidance. If you're not providing the education, you're going to be spending a lot more time with them than the diabetic educators. So you're going to be reinforcing education, helping them understand the gravity and complexity and the nuance of their management, as well as helping them integrate their own self-care into this. So education is a key component. I like to highlight here, think about the effort you're putting in to understand diabetes and you're volunteering. A lot of folks have this thrust upon them because of their health, and it can be a challenge to work to understand these topics. So education is key. So management goals are going to be to control the caloric intake to attain or maintain a reasonable body weight. So like we talked about with diet with obesity, it's not necessarily about caloric restriction or reduction as it is about good calories. Calories coming from good sources, a lot of plant-based foods, salads, fruits, vegetables, and obviously be careful with fruits there because of the sugars that are involved. But the raw fruits themselves have fiber in them, which help mitigate some of the spikes you might get from fruit juices. So fruits are still on the okay chart for these patients, but we want good calories for these people, not French fries and French fries and hamburgers and fried and chicken strips and things like that. Definitely, we want to control blood glucose. The parameters for this are going to vary slightly. Generally, what they'll tell patients is we want to maintain their glucose level somewhere between 80 and 140. Remember, normal for us is going to be, 80 to 120. For these patients, they've got a little bit of latitude because there's going to be more of a challenge. As they normalize their glucose levels and keep them under control, and also with their diet normalize lipid consumption, that can help with management of blood pressure. And if not, then they need to be on antihypertensive, because these three things together, diabetes, elevated lipids, and elevated blood pressure, hypertension, are three hallmarks to developing heart disease and dying of heart attacks. So that's why we definitely want to avoid, because this portion of it has a great deal of preventability to it. So as I mentioned before, our role as individuals is to be knowledgeable. So we're giving good information, not Joe Rogan's take on the latest diet trend, or Dr. Z or whoever's on TV and saying, or even I've even seen videos that are supposed videos of Tom Hanks. I don't know how accurate they are or not, espousing different notions behind dietary and medication management of diabetes. We need to be knowledgeable about what is evidence-based, what the American Diabetic Association is saying, what the American Medical Association is saying, what research is saying. And by that, I mean, not that you have to be researching this stuff but you have to be conversant with what's evidence-based care is being provided out there at your institution and other institutions. So we're giving patients good information. We need to be knowledgeable about that, and we need to communicate. Several not several. We need to communicate key pieces of information that we acquire from the patient or other specialists, endocrinologists, or whoever that are involved in the case, that indicate things that bring value to the patient or challenges they're having that they may forget to communicate when the diabetic educator's there, because they're trying to listen to them, they're trying to listen to the doctor. So there may be things they share with us that may not come out in those conversations. It's important for us to communicate, this person really values being able to do this and they feel like they can't. That kind of information helps establish buy-in and a connection between the educator and the specialist and the treatment and the patient. And then we also are going to be reinforcing understanding. So as things come up through a 12-hour shift or multiple days of caring for a patient, and didn't that endocrinologist say blah, blah, blah? No, what he really meant was, and clarifying, or you nailed it. You got exactly what he was talking about. Those kind of things are important to help patients know how to proceed. And then also giving examples on a day in, day out basis, meal to meal basis, how they can support dietary changes, that we can switch out this for this, or, I really like to have a cola. Well, how about a non-sugar cola? That's a good, you get the fizz and, you don't have the sugars. So things like that is a good place for the nurse to be able to insert herself in the management of these patients. This slide is from a textbook of internal medicine that shows you, kind of gives you some guidelines for meal planning. I don't expect you to memorize this, but this is like a good resource for you to have in the future, tucked in as you're trying to help your patients understand. You may have to explain some things on this list, but it has, let's minimize trans fats. Mediterranean diets are rich in monounsaturated fats, and that could be better, for you. We need to monitor our we need to count carbs, monitor our carbohydrate, how many calories of our diet are coming from carbohydrates. That's what I mean by carb counting. Watching for sucrose. Sucrose is a sugar that's not easily managed by the body and can really cause spikes and problems with glucose management. So these are just examples of things that help, little pieces that help management. Other components have to do with the types of sweeteners that we use. So we talk about nutritive versus non-nutritive sweeteners. A non-nutritive means it's a sweetener, doesn't have any calories in it. So it doesn't have any form of carbohydrate, even if it's a reduced carbohydrate, compared to regular sugar. It doesn't have that in it. It's just an alternative sweetener. So this is just a good guideline for some dietary meal interventions. And notice at the top, for type 2 diabetes and pre-diabetes, weight loss is a key component in that. I have this for you as an example. I don't want you to memorize this. We'll talk about this more in class. This is a handout for what's referred to as the Turkey method. I'll explain where that came from, but this is a simple way for a patient to learn with their hand a way to efficiently count carbohydrates, and can help them know how many carbohydrates are coming from their food, which foods don't have carbs in them, so they're okay, and what a portion size would look like. And if they're diabetic, then if they're insulin dependent diabetic, how much insulin they could support their meal with. All right. Another component that's important with with consuming foods is understanding their glycemic index. Because just because a food is a starchy food or a carbohydrate doesn't mean it's necessarily bad. For example, there's really not you could eliminate bread, but that's a high mark to set for someone to eliminate bread. But white bread has a very different glycemic index than does whole wheat bread. So those whole wheat breads have a higher glycemic index, which means they're not going to spike your sugars as much as a more simple carbohydrate might, or one of those breads that's higher in processed sugars or processed carbohydrates. So it's not as processed of a food. So also raw foods, as opposed to cooked or pureed foods, tend to have a better glycemic index for these people, which means what's happening is when we cook foods, all foods we cook some of the nutrients out of them. Now, there's some things we have to cook, such as meats, because there are diseases that can be contained in the meat. But things that we can eat raw are actually better, such as fruits, for example. We'd like for these patients to stay away from fruit juices, which is one of the bullet points here. But it's an example of this raw or whole food. An orange is okay compared to orange juice, because orange juice obviously has had some preparation involved, and that is going to have a higher glycemic index because the raw food has other components of fiber that help prevent that dramatic spike in sugars. And the fiber also helps slow absorption, which is part of how that sugar does not spike as high. And then adding foods with sugars may produce a lower response if they're eaten with foods that are more slowly absorbed. So there may be things that they have kind of a sweet tooth for, but if they eat them with something that's metabolized and broken down more slowly, that may slow the process in absorbing that food. Here's a good example, a good kind of concrete example. If you're at a party, if you're going to go to a birthday party and you're a diabetic and you want to be social and you like cake and you want to be social and eat some anniversary cake or birthday cake or whatever it might be, you'd like to have a piece of that cake. Well, if there's not food served at the party, then eat something before the party that's going to be in your stomach when you get there to have the cake, that's going to be broken down more slowly, and that will then subsequently allow the sugars to be more slowly absorbed. So you may eat more complex foods before you go, things that are higher in proteins and fats, and complex carbohydrates that have a very good glycemic index. So those foods will help your cake not spike your sugar. So that is a way to help manage these conditions over time. Some things that we also have to be concerned about, obviously, are alcohol. Have to be concerned about that because it can definitely have an effect on sugar and also have an effect on pulling fluid into the system, have a diuretic effect, which can complicate glucose issues as we're trying to manage this condition, not to mention the chronic organ damage issues that can be associated with alcohol. And then we've already mentioned nutritive versus non-nutritive sweeteners. So the nutritive sweeteners, as I mentioned, are sweeteners that still have a sugar component in it. It may not have as much of a glucose element as cane sugar. It may have another type of sugar as the sweetener. It may have a little bit of sugar and then some chemical that is a sweetener, but it doesn't have a carbohydrate component to it. But it had the point being, if it's a nutritive sweetener, it has a calorie. It creates a calorie, which means some of that sugar in some way is going to be metabolized as sugar. A good example is people will think honey is okay as a substitute, and honey metabolizes to glucose. So that's going to be a nutritive sweetener. Whereas non-nutritive sweeteners basically have a synthetic chemical that creates the sensation, the taste of sweetness, without it being a carbohydrate. It doesn't have a calorie associated with it. And kind of related to that would be food labels. There are things like maltodextrins and other components in food that may or may not be counted in the carbohydrate count. Typically they are. If they have a carbohydrate contribution, they're going to be counted. But reading those food labels to make sure to be dialed in to foods that could spike your sugar. An example of this that I like to reference is I had a physician that I worked with who was a diabetic, and he mentioned something about not being able to eat McDonald's French fries. And, I thought, so you're just trying to be healthy? And he said, well, it's not just that. I love the taste of them, but they have sugar mixed in with the salt that's applied to the French fries. Now, I don't know if they still do this. My guess would be yes, but that's something that may not show up on a label. I don't know that there are labels, or I don't know how those labels are presented in McDonald's. Haven't been inside a McDonald's in quite some time. So, but that's an example of where a sugar might not show up on a label or an indication. It may just be included in the carbs, but it's a sugar that's doing it. It's not from the potato, those starches. So definitely the goal of exercise is to help overall over time lower blood sugar. Diabetics have to be dialed into glucose monitoring around exercise, because exercise can both lower glucose, and over extended period of time, it can also cause sugars to go up if the patient were to exercise to the degree that they shift into a ketosis. And, in a type 1, they don't have insulin to kind of balance that. So obviously the exercise can cause you to burn up sugars, and somebody can become hypoglycemic from that. Now, ultimately, exercise also aids in weight loss, managing stress, and overall sense of well-being. Those are those other hormonal components that I mentioned earlier, that exercise being a key component of their treatment helps their overall health in these ways, as well as lowering cardiovascular risk. So we definitely want these people doing some form of exercise. They don't have to be doing CrossFit, training for marathons or big runs or anything like that. They don't have to be doing 100 push-ups a day. They just need to be doing something for their health, intentional and purposeful exercise, and not just casually walking. So I've already alluded to some of the precautions that exercise can also elevate blood sugar. So that's where I was referring to when they've exercised for a long enough period of time that they have depleted any glycogen or glucose that insulin was covering, then the liver may shift into gluconeogenesis and fatty acid metabolism, which then causes sugars to rise because there may not be insulin to address that process. So again, before, during, and possibly after and possibly during exercise, these patients need to keep a kind of a check. This is what makes the self-monitoring devices so handy and so beneficial for patients these days. As I mentioned before, insulin usually decreases with exercise, and it's not a bad idea for them to eat some form of little snack just to keep things even as they move through their exercise regimen. I Earlier mentioned the post-exercise hypoglycemia. So if they don't get to the point of fatty acid metabolism, then they could become hypoglycemic from their exercise. So exercise becomes a delicate component to be dialed in on. How is a patient, how is that going to affect my sugars? How am I going to respond to that? And that reflects the need to monitor glucose. As patients get older, generally basal metabolic rate decreases over time. So that may affect how insulin acts for these patients, how their medications act for them. So there's much to consider here. If a patient's on an oral hypoglycemic that is heavily cleared by the kidneys, and as we age, the patient loses kidney function, then that oral hypoglycemic agent may be circulating in the bloodstream and be more effective than it was 5 or 10 years ago. So that's a consideration. Another consideration is as the metabolic rate slows, the same amount of foods that they've been eating may produce higher levels of glucose in their bloodstream. So dosages may have to be adjusted. Assuming kidney function is fine, doses may have to be adjusted up to accommodate the higher sugars from the same amount of food because their basal metabolic rate has dropped. Another consideration here for the gerontologic population is older elements of the older strata of the population tend to eat smaller meals more frequently. This is not always the case, but some people will tend to eat multiple small meals throughout the day, and generally associated with changes in sleep patterns. So their sleep patterns, they may not sleep 8 hours a night. They may sleep in 4-hour segments and may eat around that. It is important that they be diligent about monitoring sugars because their normal circadian rhythms are going to continue to cycle. Melatonin and cortisol are going to continue to cycle on those normal circadian rhythms, but yet they may be sleeping and eating at various times, and so metabolism can generally be impacted by, or sugars can definitely be impacted by those alterations in cortisol, as well as these times of day and the sizes of meals. So there's definitely some changes that need to be considered as people age, and this may start with us inquiring with them, what's a normal day like for you? Or you get up at night, you having a midnight snack? Okay, not at midnight, 2 o'clock in the morning. You get up around 2 and have a snack, or you up for a little while, those kind of questions. So we will pause here before we get into the oral anti-diabetic agents. We'll go into this, and this is going to be a bigger section than I can cover in a 20 or so minute video. So we'll stop here.